Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Good afternoon, everyone. Thank you very much for joining us for this brief webinar on the final rule. Very pleased to have Arlene Maxim, who is Axxess's Senior Vice President for Clinical Services, joining us. My name is Mike Carr. I'm the Senior Product Manager for our Axxess Training and Certification Program, and I'll just give you a couple little ground rules, and then we'll go ahead and let Arlene get started. So first of all, if you have any questions during the presentation, please don't raise your hand, and please don't use the chat panel, but enter those in the questions panel that you have along the right-hand side of your screen in that GoToWebinar box. So we'll capture those questions, those that we can answer during the presentation or at the end of the presentation. We will. Those that we don't have time for, we'll certainly get back to you via email on those. Because Axxess is accredited by the ANCC, the American Nurses Credentialing Center, we're able to provide a 0.5 continuing education unit for today's presentation. So we're happy to extend that offer to you. The way that will work as far as the certificate is concerned is that will be distributed through the training and certification program. So for those of you who use Axxess solutions, you'll have in your Axxess Planner a button for the Axxess Training and Certification. When you go there in the top center of your dashboard, there'll be a box that says Axxess/Complia with the webinar links for that. And once you click on that, you'll be taken to a section where you'll need to complete a little survey, answer a couple of questions about today's presentation, and then you'll get your certificate. It'll take us a little bit of time to get that all put together, so we'll send out an email to all of you when that will be available for you. For those of you who don't use Axxess Training and Certification, we'll send out another communication letting you know what's going to happen. Essentially, we're going to create an account for you, and you'll be able to go through those same processes once you create a password. But we'll explain all that to you in an email, and certainly if you have any questions about that process, reach out to certification@axxess.com or mcar@axxess.com, and we'll be happy to get things moving forward. So that's all I have. It's all yours, Arlene. Thanks for spending your time with us and sharing some of your thoughts about the final rule.
Okay, so thank you so much, everyone, for attending today. Not sure how many of you have been involved in final rules with CMS in the past, but every year CMS comes out with a proposed rule right around July, and then right around Halloween, we get what they call the final rule. And the final rule is based on information that the CMS has received from providers on what they had as the proposed rule. And with the final rule, that tells us what we can expect for the year of 2024. Now, they do take the comments that folks write in, and I always encourage everyone to make comments on the proposed rules, because most often they are not rules that we would choose to write ourselves. So we want to make sure that we have our voices heard. And the final rule, as it turns out this time, in a sense, has not turned out as badly as we thought it could have, in particular the financial part of it. However, there are some implications with this final rule that can be pretty disturbing. And so we need to maintain a grassroots level of comments to our congressional folks. There is absolutely nothing wrong for you all to be communicating with your representatives in Congress to let them know how you feel about things that are going on. CMS has some control of what they make decisions on, but Congress, you've probably heard, it's going to take an act of Congress. Well, oftentimes it's the congressional folks that are going to be the ones that make some of the final determinations and recommendations for what CMS needs to do. So the objectives for today, we're going to talk about home health aid oversight. And part of what has happened over the past couple years is that the home health aid services have been diminished since we started with our billing with PDGM. And so there's some things we'll talk about there. CMS changes in reimbursement. Again, that turned out a little better than what we thought it was going to turn out, but there's some things that are tagged onto there that we're not all that happy with, and we'll talk about that. We're going to look at some of the changes in the OASIS-E assessments that are going to have to take place probably during the first quarter of 2024. And then new reimbursement winners and losers, and I'm going to include a list of some of those, and how to reduce your risk of data breaches using high trust certified solutions is actually not part of this. That was in a previous session that we did. So that is not an objective that we are going to be working with today. Okay, so on the left-hand side, all the way through these slides, you're going to see what the proposed rule was, and that was the one that came out during the summer. And then on the right-hand side, we have CMS's final rule. So what we can expect for 2024. So the proposed rule was very painful. They were talking about having a 5.1% decrease in reimbursement. And they came up with that decrease as a result of what they call behavior assumptions. So when PGGM came into play a couple years ago, they made a decision, CMS made a decision that we were going to change our behavior in how we actually performed in-home health care. So they expected some reductions in different services. What happened though, when PGGM was introduced, we all had an unexpected guest called COVID come into play, and COVID kind of took over our world, literally. But what happened during that time, even though we had a lot of training in PGGM and the billing and how it needed to go, we all had to deal with issues regarding COVID. So some of the behavior assumptions that they had back then were not any that came about because we were just trying to take care of our patients the best we possibly could. That went on for 2 years. Well, in the meantime, there had been some changes in the way we did services. For instance, we decreased the number of aid visits that were being performed, and I'll get into that in a little while. Therapy visits, we changed the way we provided therapy to patients and that type of thing. So we didn't have all the behavior assumptions that they thought they would need to adjust on, but there were some that they could show. The good news regarding what the proposed rule said was they did not come up with that 5.1 decrease right now. They actually gave us a tiny little bit, 0.8% increase overall. But with that, they did not consider inflation. They did not consider staffing shortages and everything else that you all probably have been victim to, and most every agency in the United States has had to work around issues regarding inflation and staffing shortages. Those are not going to go away. Inflation continues. Staffing shortages are not going to go away. We have folks that are aging faster than we can come up with a supply of nurses and therapists. So that issue is going to be with us for some time. And again, CMS did not consider that So I told you that we had some winners and losers, and here is something that the National Association of Home Care actually presented a couple weeks ago in their webinar. And you can see, because of the wage index and some of the differences in CBSA scores, locations of the areas, some folks will have an increase in the amount of money they will get, but there are going to be some folks in some areas that are going to actually suffer a decrease. And with their wage index the way it is, California is going to probably be hit. There's going to be more cities in California that will be hit worse than other cities. So it's going to be interesting to see how people work with the strategy that CMS used. It's basically about a $27 increase per visit overall, per episode, I'm sorry, overall, with the changes that they've made. But you can see here, if you live in some of these areas, you can see here where you're either going to get a little bit of a bump or you're going to have money actually taken away from you. The behavior assumptions that I just mentioned to you, they talked about making changes in the clinical grouping of coding, so that the grouping models that they used in PDGM, they had specific groups of patients like neurological patients, orthopedic patients that paid a little bit more. There were differences in pay than some of the other clinical groupings. Those patients who had comorbidities, we wanted to make sure we coded those, because then that could boost the reimbursement up just a little bit. The LUPA threshold is going to change. There has been a LUPA threshold that we've been living with for the past few years. They are going to make some adjustments to that, and we don't know what those are right now, but those will be delivered to us shortly before the first of the year. So the law requires CMS to annually review the differences between the assumed behavior changes and actual behavior. And the analyzed differences here were between episodes billed prior to the 30-day billing episodes and afterwards. So those 30-day billing episodes were different for us. We're now billing every 30 days. We used to bill we used to get a RAP payment. Some of you have been in the certified care know about that. And then we would either get 60% on new cases or 50% on research, and then 50% at the end. In 2023, they came up with something called the Notice of Admission, an NOA. And that Notice of Admission allows us to proceed with care with the patient as long as we notify CMS that we have admitted the patient, so that other providers understand that the patient is under admission with our particular home care agency. So that NOA started again in 2023, right along with OASIS-E. And that allows us then to bill every 30 days. So we no longer have that advance that we had with the RAP payment, but we do have the notice of admission we're required to submit. The LUPA rates, of course, are going to change, as I mentioned, and those will be coming out very shortly. Negative pressure wound therapy, some agencies that are using that, they decided they were going to codify the requirements for this. And so the equipment itself, this is going to be primarily a DME issue. The healthcare providers will only be responsible for the visits, but there's a change in the reimbursement for the negative pressure wound therapy that's being provided in the home. And again, only the home care providers will be responsible for the actual visits. The recalibration of PDGM case mix weights, as I mentioned, we have groupings models with coding. So there were 432 payment grouping models with associated case mix weight and LUPA threshold changes. There's no change from the original prediction that they made. So that recalibration will take place, and again, that's going to be delivered to us right around the first of the year. It may be a little afterwards, but right around the first of the year, we should know what we're facing as far as that's concerned. There was a concern, and the OIG did a study not long ago on access to home health aid services. What they found in a lot of the data that was being submitted had to do with the decrease in the number of home health aid services that were being provided in a number of home care agencies. CMS has a concern that the patients are not allowing the benefit to the patients for home health aids, for the provision of home health aids. They did not change their opinion on that. So they decided that this is one of those behavioral changes that the industry made, that the home health aid services the lack of home health aid services are a problem. They are going to impose a focused assessment on claims paid with no aid services billed. So the prediction is that the MACs, those folks that actually pay our bills, are going to start watching the bills that we prepare and that we send into them. And if there are no aid services provided on certain cases, that is going to be, that could be a target for a medical review. They have not said specifically what exactly is going to happen with that, But my hunch is, and with my experience, I believe that that's going to be a targeted area. So if they find AIDS services are not in the home, and based on the other data in the OASIS assessment, they could be looking at those services and doing ADRs and medical reviews on those. The other thing I believe might happen is there's going to be increased scrutiny during surveys. So if AIDS services are not provided, and they find that AIDS services should have been provided based on patients' diagnosis and comorbidities and that type of family situation, then the surveyors, I would guess, are going to be citing those more often. I can tell you that I just recently helped an agency with a plan of correction. The surveyor went to the home, and prior to going to the home, they reviewed the record, and the record indicated that the family refused home health aid services. When the surveyor got to the home, the patient and family was asked about the AIDS services, and the surveyor could tell that they were needed. The family and the patient indicated that they had never been offered services by the home health agency. That's going to happen more often now. And with that study that was done, I would guess that there's a potential for immediate jeopardy findings, which means that the patient could be placed in harm's way, or there was harm to the patient as a result of not having these services available to them. So we need to pay attention to that and watch. I think this could be a bigger issue than what some folks are making of it. I think that there's going to be more reviews on this. The quality reporting, they're going to add the COVID-19 vaccine and the percentages of patients with updated vaccines. And there's going to be a functional discharge score measure that's going to be added to the quality reporting. That in itself, the discharge score, probably isn't going to be very painful. However, adding COVID-19 vaccine to the quality reporting is potentially going to be a problem. We have a significant issue with clinicians collecting the data that's necessary for reporting flu vaccines right now. And we have the requirement on HCS-C is we also collect information on pneumonia vaccine, but often the clinicians don't have access to information. If the family members or caregivers aren't in the home, patients aren't remembering when they had the vaccines. The other problem we have, so one of the things we could do would be call the physician's office, check with the hospital, if it was a hospital discharge, and see if they had information. One of the things that's going to be problematic here is that many of these vaccines are given in pharmacies. And so many of the pharmacies aren't keeping the records that they need to keep, and patients aren't remembering what pharmacy they went to get the vaccine. So getting that data, unless they have a written document indicating when they received the vaccines, and certainly keeping up with all the boosters and that type of thing, could potentially be a problem. They did not make that change in the final rule. It's the way they proposed it is going to stay. So those quality reporting measures will be changing, and we'll see some of those changes coming up during the first quarter of the next year. Some of the QRP items that they're removing are episode timing, whether it's early or late, and then that 2220, which has been, we haven't used that for quite a while. After PDGM, we haven't been really paying attention to how many therapy visits were being provided as far as a data processing item. Certainly we paid attention as to what the patient needed, but as far as reporting that, it hasn't been an issue. So there hasn't been any change in the final rule. But again, this is another place where HCS-C is going to have to change. And so you'll see that change coming up shortly, I believe. I haven't seen anything in writing as to when HCS-C will be changing, but that'll be another time when we're going to have to be training staff, retraining staff on HCS-C and the new items that they want to have added, and some other things that'll be added to HCS-C. So again, these two items are related to the previous PPS and not to PGM itself. So the episode timing therapy needs were all used in the previous billing, the PPS billing. As far as public reporting to be added, there was no change in that. So they are going to be adding information in their star ratings regarding discharge function, transfer of health information to provider, post-acute care measure. This is going to be another place where OASIS-E information will change. The conditions of participation that the surveyors use now includes information about timeliness of transfer of health information and the information that needs to be provided. That data now will be included in public reporting, so the patients and the family members will have, consumers will have information about how well these home care agencies are making that transfer information available to the provider being transferred from post-acute care. The percentage of patients who are up to date on COVID vaccine, again, this is going to be an issue because it's very difficult to get information about dates of vaccines. And again, depending on where the patient is going for their vaccine, and if there's record of it, this is going to be a challenge for some agencies. So coming up with policies and procedures to comply with some of these things is going to be really, really very important. So there was an expanded value-based purchasing model that was proposed. They have not changed anything on that in the final rule. They're going to replace self-care and mobility with transfer function score. I just mentioned that a couple slides ago. They're going to replace OASIS-based discharge information to the community with claims-based information discharged to the community post-acute care measure. That claims-based is actually coming off of the billing claims. So they're not taking it from the data, the OASIS data itself. They're going to replace claims-based acute care hospitalization during the first 60 days of home care and the ER use during the first 60 days with claims-based potentially preventable hospitalization. So that information is going to be collected, again, using hospital and home care claims to calculate that data. The painful area for some agencies is that they've switched the baseline year for value-based purchasing from 2022 to 2023. And by painful, I mean that a lot of agencies worked really, there were a number of agencies who really understood value-based purchasing, worked very hard to improve their data from 2022 to 2023. So they worked really hard to train their staff and improve their data. Well, now all of a sudden CMS decides, no, we're not going to use the 2022 data. We're going to use 2023. So now they have to make the improvements from 23 to 24. For those agencies who did not pay attention to value-based purchasing, and there are a number of those out there, this is good news for them. But for the others who worked really hard and took it seriously, it was kind of a disappointment, I believe. And but whatever, for whatever it's worth, that's where we are. And so again, payment on value-based purchasing will not be until 2025. So it'll be interesting to see how these how agencies respond to this and what they're going to do to work on improving those measures. There's a health equity update, reassuring stakeholders that CMS is developing approaches for meaningfully incorporating advancements to expanded the home health value-based purchasing model. So health equity is a concern across all provider types. And so that's going to be unchanged with home health. And there was no change in the final rule. Their plan for that will continue. Immune globulin IV changes, the coverage for these changes are going to be related to the administration of this. And this all started, of course, again with COVID. So there's currently a demonstration project going on that's going to end at the end of the year. There is going to be a permanent coverage and payment for such items. So we'll get more information about this and how the agency will get paid on that. But we will be getting paid for providing the injections for this. or the IVs for this. Included in the home health final rule, and I'll go through this fairly quickly because we just have a couple minutes left, but included in the final rule, there were some hospice changes in here, and there weren't any changes in the final rule. And when I listened to the NOC webinar, they kind of mentioned that they were concerned that some of these changes may roll up into home health as well. So one of the things, and if you are involved in hospice at all, you're going to want to pay attention to this, but during COVID, the ownership of 5% or more, the folks that had a 5% or more ownership in hospice did not have to go out and get fingerprinted. What they want to have happen now, and what will happen, is that those folks that were not fingerprinted, but they have 5% or more ownership in hospice, they will have to go get fingerprinted. And we believe the same thing is going to happen to home care, but they have not mentioned that yet. They're going to expand the home health agency, change the minorship owner provisions to include hospice changes, minority ownership. So the same type of thing we have in home health will be, majority ownership, I'm sorry, will be added to hospice. And then a managing employee definition is going to be changed. So that's going to include the administrator and medical director. So that'll have to be included on your 855. They're going to reduce the non-billing period. There has been a provision that if you did not bill within 12 months, your provider number would be discontinued. Now they're going to decrease that time, excuse me, to 6 months. So that could be a problem for many providers, so they're going to have to pay attention to that. And again, right now this is just hospice, but we in the industry believe that it could come out with home health as well. And then they're going to have a strengthening of oversight claims on hospice. We've already seen that happen. Many more UPICs, many more ADRs coming through for hospice, and that will continue. There's going to be a special focus program, and there's going to be a way for hospices to provide an informal dispute, an IDR. Home health has had the IDR for some time, but they are going to increase significantly the number of reviews that they're doing on hospice. That was not changed in the final rule, but it's very concerning to everyone because there's going to be an algorithm that they use, and there will be, like I said, more, the short version of this, there's going to be more audits done with hospices. And because hospice has been not really paid attention to as far as documentation is concerned, this is very concerning because they can go back for a couple of years. And so they are going to be looking for immediate jeopardy. With immediate jeopardy carries significant fines, daily fines. Those of you who have ever worked in nursing homes know how painful that is. These are a number of references for you all as far as the presentation today. The one thing I did not cover that I just want to mention to you is there is in the final rule, there was a clawback provision, which means that CMS is going to look at what we have billed over the past number of years in home health, and they are going to claw back money. There is a percent of money that they're talking about. It's in the, for the industry, it's in the millions and millions of dollars. The clawback, they have not told us how they're going to do that. They've not told us that we're going to have to write a check at the beginning of the year or with our cost report. They haven't told us what they're going to do or how they're going to recover any of that funding. So we'll have to pay attention to see how that shakes out. The other thing I just want to say before we end this is that all of this, much of this could have been prevented, and much of this could be prevented in future years with responsible data collection, making sure you have an EMR that's collecting data the way they need to, that the clinicians are collecting data during their OASIS-E collection efforts in the home, and they are putting responsible data into the clinical record, and also cost reports, that home care agencies are finding cost report preparers who understand home health, understand hospice too, but understand home health specifically, so that these errors and judgment on CMS's part does not happen to us again. This is going to be a painful experience for all of us. But again, I'm just telling agencies now that we need to be more responsible for the data that CMS is receiving. Thank you so much for attending today, and on behalf of Axxess and all of us here at Axxess, thank you for being here with us, and look forward to having you at our next webinar.
Great, thank you, Arlene. We just had one question that came in that I answered in the chat, but just to make sure I answered it correctly, I'll run it by you too. Someone was asking about why the episode timing was being removed from the OASIS, and my thought is that since it's really not determined by how we answer it on the OASIS, since it really comes from the claim, that it was really just a cleanup piece on CMS's part. We just don't need it, so why answer it? So.
Yes, that's correct, Mike. Thank you so much for doing that.
But that's all we had for questions. Again, reminder about the CEUs. We'll be reaching out to you by email to let you know the process and the next steps and when it's ready for that. But again, thank you, Arlene, and thank you all for your time. Hope you enjoyed the session, and enjoy the rest of your day, and happy Thanksgiving.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.